The chemotherapy of head and neck cancers, I'll try to explain what we mean with head and neck, and as you just noticed, it's different parts of the head and neck area because it's a very complex part of the body because of the anatomic features which are there, and also the fact that you don't want to lose the function of any of these organs. And I'm sure you have heard about these things, and I think Dr. Kim did the radiation oncology, and Dr. Pettis did the surgical point, and they explained how important it is to keep the patients functional. Usually the cancers could be at the lip, oral cavity, which is around the gingiva and those places, oropharynx, the area around the oral cavity and pharynx, and hypopharynx, which is the lower portion, and glottis, which is a device that closes the airway when we are swallowing, and epiglottis around that, and of course tongue, very functional portion of the head and neck region to prevent, as a resection of it, prevents ability to eat and speak and all those things, and also salivary glands, exactly like what you just mentioned. Because even if I have to go to another one, he has to be here to connect this to us. What I'm doing is page up, page down, and somehow when we turned ourselves off and we started again. So the point would be the cancers of head and neck, the majority of them are squamous cell carcinoma, as was mentioned. The cancers of salivary glands are, well, I'm dabbling, okay? It bleeds by itself. That's okay. So squamous cell carcinoma is the most frequent one. About 90% of tumors are squamous cell carcinoma. Other cancers like melanoma, which we're all familiar with, could happen inside of the mouth, and also in the eyes, as we are aware of that. Adenoid cystic tumors are the type of tumors that are usually in the salivary glands, and they are totally different type of tumors. Occasionally, patients with salivary gland tumors may have a squamous cell carcinomas as well. And of course, lymphomas. Lymphomas and tumors related to that could happen in the usually back of the throat, where we call it the Waldeur's ring. Could be also happening above the nose. So it's very important to find exact diagnosis before embarking on treatment, because each of them have different treatment. With melanoma, the treatment would be mostly melanoma. One would try to resect it. With adenoid cystic tumors, radiation therapy plays a major role after removing it, with adding even the gamma knife or cyber knife or whatever they can. And it has a special feature that new targeted treatments actually may work on that. Lymphomas are a different ballgame. And squamous cell, we have a group of lymph nodes in the throat area. As I said, we call it Waldeur's ring, which the tonsils are part of it, and there are a couple of them above it and above behind the nose. And also there is another type of tumor, we call it plasmacytoma, which is related to lymphoma. That also can happen in the upper airway region. So that could happen. And they could be actually lymphoma rather than a cancer of a squamous cell type or melanoma which has metastasized to the lymph nodes.
Does that show up in normal tests?
In normal tests, usually not. The typical person is a person who complains that I'm having some difficulty breathing, my nose is congested, and they try to use local measures. It doesn't work. Sometimes they come up with frequent nosebleeds, and then when they do a CAT scan or MRI of the head and neck area, they can see the mass. It can be resected if it is a small, surgically, and sometimes if it is just limited to that area, unlike other lymphomas of the body, those type of lymphoplasmacytic tumors of the head and neck area, they just remove them and just watch them. And that could be a curative approach, very unlike the rest of the body. I had one gentleman who apparently, who was sent to me actually by an ear, nose, throat specialist, who had a nosebleed and coughed, and a piece of tissue came out, and his wife, who was a nurse, was smart enough to take the, of course, all the nurses are, pick up the tissue and took it to him, and they sent it for pathology, and it was a lymphoma. And he was treated just like a lymphomas are treated. And he did very good for many, many years after that. So I'm going to push one of these buttons. I hope it works. It worked. Very good. I think it's just starting to. But the interesting thing I would like to mention was, typically we were accusing a person who has a head and neck cancer to have smoked too much cigarette and have combined the smoking cigarettes with drinking. That used to be the story of years ago. Recently, the HPV, human papilloma virus, is becoming a factor. Actually, we are seeing a significant increase in patients who have the squamous cell carcinoma of head and neck related to HPV virus. The type which causes this is called type 16, and somehow the tumor is aggressive, but responds very good to chemotherapy as it's given to the patients. We don't know what happens in the long run, but definitely it's a new cancer. It is seen in younger people, but anytime these days they see a cancer of the head and neck, especially in the throat, which is a squamous cell carcinoma, they test them to see whether it is related to human papilloma virus or not. Human papilloma virus is a virus which is associated with development of other cancers, including cancer of the cervix and cancer of the anus. Both of them are squamous cell carcinomas, and it is believed that the vaccination definitely prevents development of the other two. It should have an impact on diminishing the number of patients who develop the cancer of head and neck related to human papilloma virus.
And what vaccination are you referring to?
We're talking about there is a vaccine to prevent cancer of the cervix. They were starting it to be given to the young ladies. Merck company is the one that makes it. And actually the recommendation is to start to give it to a person at age 13. And then later on it was suggested to be given to men also. And by doing that it will diminish the transmission of the virus from one person to the other. And as you know, in cervix, in cancer of the cervix, the uterus cervix, it is diagnosed very early, but if it is not diagnosed, it could be a devastating disease. Like we talk about celebrities like Eva Peron had one of those. You know Eva Peron? The movie Evita, Don't Cry for Me, Cry for You. So that's the type of cancer that has diminished significantly by chronic and careful monitoring of the patients, and now hopefully with the vaccination, that will be one of the first cancers that the development of it will be prevented. Interestingly, coming through, there is a new entity which is being reported since I think 2010, 2011. There is a drug called doxorubicin which is used for treatment of different cancers. Plain doxorubicin has been used for treatment of lymphomas and Hodgkin's disease. They have made it what we call pegylated liposomal. They make some changes in this drug to make it long-acting and with having less side effects. The regular doxorubicin can be given for only 9 injections. After that, becomes toxic to the heart. This one, that 9 injections are about 450 milligrams. this drug, the reported patients have been taking it for 1,500, 3,000 milligrams throughout their life for treatment of different cancers, including one cancer called the Kaposi sarcoma, which is a cancer of immune suppressed person. The other one, they use that on chronic basis for patients who have cancer of the ovaries and have a relapse of cancer of the ovaries to maintain the cancer under control. Interestingly, now we are seeing reports of cancers of head and neck and squamous cell carcinomas developing on these patients. It should be related to the drug. They are really, everybody is excited about that. Everybody who sees a patient who has cancer of the, or being treated with this drug and has a cancer of head and neck, they don't treat them just, they try to do every test possible. I think there was one group of 5 patients, 4 of them had genetic predisposition for developing breast cancer. You have heard about it, BRCA1, BRCA2. It's a genetic study done for breast cancer. One of them did not. The patients who have that particular genetic abnormality may have a higher risk of cancer of the breast as well as ovaries, and they were being treated. There have been no report of that genetic abnormality inducing cancer of head and neck. So now we are seeing from the success of chemotherapy, a new cancer is evolving, but considering the reasoning that those patients were getting the drug, it is a sort of a justifiable mean to keep on using it. It's not clear what is the frequency of this complication developing, that it sort of makes the antenna of all of us go up, and so hopefully with more reporting you will see more of it happening.
How important, in your opinion, is it to be tested for HPV?
I think practically everybody should be tested. When they develop cancer of head and neck, practically everybody should be tested. Yeah, I think it will be, the pathologists may have tested them, but you may want to ask them, because now, as we go through, there are people who are saying that if you have HPV and it responds better to chemotherapy, should we treat the patient more gently than the standard treatment that we give on a person who has a regular cancer of the head and neck. I think it may not be a bad idea just to know out of curiosity. It's a test that is done on the tissue. Usually they can identify, and if the tissue is already beyond that phase, they can do a blood test for you and find out whether you have a test positive or not. It would be important because that is a virus that can be transmitted to people who kiss you, French kiss. So that is important to recognize it.
I have talked 13 years ago when I had cancer. It seems I can't know behind this drug.
Well, this is absolutely, as I mentioned, that's one of the drugs. But you were getting charged probably for 6 injections, which is 300 milligrams. These people have received, one of them was close to 3,000 milligrams. And also this is not the plain doxorubicin, it's a doxorubicin which has managed to decrease its toxicities with a liposomal approach and pegylation approach, make it long-acting and less toxic. But whether that approach is making it toxic or the dosage of the drug, which is now 10 times of what you have received, could have made it happen. So we don't know still whether it works or not. Okay, so the chemotherapy, which is my subject, can be done after the surgery is done based on what is the finding during surgery. The standard surgery approach for cancer of the head and neck was to remove the tumor and leave a clear margin. And if the margin was clear, then everything was great. But they were recognizing that some of these people, despite having clear margin and the good surgical approach and the curative approach, still will have a recurrence of disease. Looking back at these people gave some hints of what was the features of that tumor which made it more aggressive and made it come back, like whether it was more invasive, the number of the cells were in mitosis, which is duplicating themselves, were higher, or whether the lymph node which was involved was a lymph node that its boundaries were broken or not. So these things came to the mind, and based on that, if the extent of the disease after surgery is too much, after the extent of the disease, then chemotherapy is given. We don't want to give chemotherapy after surgery, and the reasoning for that is, in theory at least, chemotherapy needs to get to the tissues, and to get to the tissues, that tissue needs to have very good blood supply. When you do the surgery, you will disrupting the blood supply, and whether after surgery you will diminish that flow of the drug into the cancer cell, or that whatever could have been left there, we don't know. In lung cancer and in breast cancer, we have learned that in some of the more aggressive ones, if you give the chemotherapy first, you will end up having better results. So that is a very, very debatable. There's a lot of things which are debatable in cancer of head and neck, and that is one of them. 30 years ago, we used to see patients who had undergone surgery, and we would see them and reevaluate them and try to work it out whether they needed chemotherapy, radiation therapy, combination of them or not. Nowadays, majority of the patients with head and neck cancer first get their chemotherapy with or without radiation therapy, and then surgery is done. And a lot of surgeons are agreeing with that approach. So it could be done after surgery, it could be done before surgery, it could be done before radiation therapy, or it could be done in conjunction or combination with radiation therapy. These are at the earliest stage. And of course, it can be given for patients who have recurrence of their cancer, or they have evidence of metastasis in other sites of the body. So do you think it's going to work this time? Yes. The typical drugs that we used to use in the past, one of them was a drug called bleomycin. We are not using it anymore. It's a very good drug. It's still being used very successfully on management of testicular cancer with, you remember, Lance Armstrong and all those things. That is not being used. Another drug was methotrexate. Methotrexate is a very important drug because my going too slow, am I going fine? Okay. If anybody wants a 10-minute break or something, please let me know. I'll be happy to give a break. Because when I get excited to talk, then I forget stopping. So the methotrexate is a wonderful drug. It has been around for many, many years. And as we are hearing about targeted drugs, this is a targeted drug. It's a drug that targets metabolism of a vitamin, very essential for the body, called folic acid. And by understanding that, the methotrexate can be given at a very, very high dose. For example, treatment of sarcomas, that you remember in 1960s or early 70s, there was one of the Kennedy family members who had sarcoma of the leg, and they did chemotherapy for him and then removed the leg, and he was still alive. That drug, the importance of it is knowing that you have an antidote for that. You can give a very big dose of it to the patient, and before it starts to work on organs in your body that you want to protect, you can give the antidote, which is about 24 hours. We used to use a lot of high-dose methotrexate in our hospital. Now we rarely use it, but that particular concept is there. And of course, methotrexate still is being used as a second or third or fourth line treatment for patients with head and neck cancer. Interestingly, an offshoot of methotrexate is a drug called Alimta or pemetrexate. That drug was originally used for cancer of the lungs and for mesothelioma. You have heard on TV about mesothelioma. It works on it. Now, remembering the history of methotrexate, Alimta is being introduced for treatment of head and neck cancers. The company which is producing that pemetrexate or Alimta is working very hard to get it as part of treatment of head and neck cancers. But at this time, the combinations that we are using is very successful. So that has to come up with a better outcome to become the first-line treatment. But just as a point of knowing that something new is in the making, methotrexate, and now the offshoot of it, which is a drug which has been in the market less than 10 years, is now being introduced to head and neck cancers. Next drug is 5-FU. That is also a targeted drug. It targets production and amino acids. It's a drug which is very old. It's probably older than me. Has been around for a long time. In 1970s, people started to say, well, let's use it different ways. And as you may have known, 5-fluorouracil used to be given as an IV push. Then they started to change it. I remember there was one issue of an oncology journal which was just talking about how to use this drug, whether you use it as continuous infusion, you use it every day shot, once a week shot, and the outcomes are totally different. So 5-FU is still a mainstay of the main drug for treatment of head and neck cancer, the squamous cell carcinomas. The other drug is, of course, carboplatin and cisplatin. These two drugs have been around for probably 30 years, but they have changed the outcome of cancer treatment significantly. Cisplatin is the first drug. It is, again, if you remember from your organic chemistry, we have everything is cis and trans. And trans is a mirror image of cis. So what Madhavi trans can do, Madhavi cis in the mirror cannot do. And that's very interesting. We have drugs in the chemotherapy, like even Accutane. Accutane works in certain conditions, and then another drug, which is a cis-retinoic acid, works on leukemia. So it's very important to recognize how tricky these things are when they work or not. So cisplatin it changed the whole treatment of many cancers, from the lung to testicular cancer, and testicular cancer, as you know, is now a treatable cancer. And carboplatin is offshoot of that. The difference of these two drugs is that carboplatin is less toxic to the kidneys and less toxic to the nerves. Cisplatin is more toxic to the kidneys and nerves, so they have limitations of what can be given to the patient because of those side effects, especially when we are hoping that our patient is going to finish the treatment and go off on his life for many years. The next one, go ahead.
I was going to say, I'm on my second year of Herceptin.
That's right. For the breast cancer. For this thing was positive, that's right.
Yeah.
Okay. Yeah. So that would be on a bunch of things I'm going to talk about based on this paper. Yeah. So yes. Typically, so we're okay now. We just don't go home. The neuropathy should not last more than a year. It is believed that it takes about a year. When there was no other option, they used to just push it. Now, when it starts to show itself, they change to carboplatin. And carboplatin in many trials have been proven to be equal in efficacy to cisplatin. And both of drugs are now available as a generic form, so the cost will not be a major issue anymore.
And anything you can do to quicken the years, so to speak, or you just have to wait it out?
No. There was an idea of giving the patients magnesium may diminish the toxicity. Didn't really work out. Yeah. And there, pardon? Just be patient. I guess there was another drug we were using which was causing more side effects, with drop in the blood pressure and everything else. That is also gone to the way. Paclitaxel and docetaxel they are called taxanes. They are from yew trees, and both work very, very good. And they have changed the treatment of head and neck cancer significantly, because with combination of 5-fluorouracil and cisplatin or carboplatin, there was significant mucositis and burning and ulcerations of the throat area. With bringing these taxanes to the picture, we could decrease the dose of 5-FU. 5-FU is a drug that is considered to be the major cause of all the damage. And now the treatment is more palatable, but it still is a long way from not being toxic. Majority of patients will end up getting a feeding tube because the ulcerations that develops in the oral cavity. And docetaxel and paclitaxel are pretty close. Now this thing is, tell them not to go away. This looks like you change it and then suddenly. The cisretinoic acid is what's called Accutane. We used to use that as a maintenance therapy to prevent recurrence of head and neck cancer. There were original studies that were showing it may help. Those studies were tried again and again, and it's apparently not as good as it was thought. Again, cisretinoic acid is Accutane, which is used for acne, and big dose of it used to help these type of cancer. Transretinoic acid works on leukemias and doesn't work on this one. Cetuximab and bevacizumab are two other drugs. Cetuximab is the Erbitux that who's getting it between, yes, that's right. This is the drug which was center of the controversy when the lady who has this, what is her name? The person who went to jail for 6 months. She has her home show. Martha Stewart, yes. Martha Stewart had made a lot of commitment to development of cetuximab or Erbitux. The studies came that it doesn't work, and then somebody says, well, it may work. They kept the rumor is they kept the data out of hand, so somehow, anyway, she sold it in the right way. Cetuximab is an anti-angiogenesis drug, and it works in conjunction with radiation therapy as well as without radiation therapy in cancer of head and neck. It also is expected to work in other cancers. It has been tried as a single agent in some of the patients with extensive head and neck cancers in hope of treating them without putting them through the systemic chemotherapy, but somehow it is not as successful in preventing metastatic disease development as the systemic chemotherapy is. Am I explaining it clearly? When a patient receives radiation therapy, it makes the tumors more sensitive to radiation therapy. In conjunction with chemotherapy, it makes the tumors more sensitive to chemotherapy. These drugs are supposed to change the structure of the arteries and veins. They're called anti-angiogenesis, and they work against the vasogenic growth factors, endothelial growth factors. So the problem is when the patient receives systemic chemotherapy with radiation therapy, it has an impact in case there is one or two pieces of cancer have spread somewhere else. With Erbitux, when they get it, apparently it does not work on the distant sites of the cancer as it works in the localized cancer. So now, 2-3 years later, the general feeling is that if Erbitux is being used for localized disease and radiation therapy, if the tumor is big enough and there is concern that it may have metastasized already, it's best to incorporate some standard chemotherapy as well. So for those who today get Erbitux have been checked on that particular factor, and they are sure that the disease is too small to worry about distant metastasis. Avastin is another drug in the same group. It works very, very wonderfully in lung cancers and cancer of the gastrointestinal system, but interestingly, in head and neck cancer, it's still in its infancy. One of our colleagues likes to use that and brings his cases and shows how good this drug works. As I said, it's difficult to prove these improvements because the standard chemotherapy, combination of trifluorouracil, platinum, and taxanes, can induce remission in about 85% of the population. So when you have a treatment which is that effective, it's difficult to prove that these things are working and adding something to it. It may make it shrink faster, but the main issue would be whether it's going to make that remission of the tumor last longer or not. And they're working on a ton of other markers. And as you know, for example, there is a group of enzymes called cyclooxygenases. These are the enzymes which are involved in growth, and inhibitors of cyclooxygenase, simpler ones, are drugs like aspirin or Celebrex. But those inhibitors are not strong enough to inhibit the growth of these tumors. So when they wanted to use big dose of Celebrex to control the cancers which were showing the cyclooxygenase activity, the Celebrex side effect was more than what was appropriate. There were some heart attacks and these things happened, and so that goes to the wayside. The other enzyme is what they call tyrosine kinase enzymes, and the tyrosine kinase inhibitors, they originally were identified to work on leukemia. Let me see if I can. That's a side effect. We'll keep it for next time. Yeah, just let's be. So those tyrosine kinase inhibitors, when they were identified, they recognized it works on some of the patients with chronic leukemia. Then they identified the same abnormality in some tumors of the parotid gland called adenoid cystic tumor, and it interestingly works on them. Also, there is a tumor of the gastrointestinal system that it works on them. But they have identified potential of benefit from these type of drugs that inhibit this enzyme in head and neck cancers. But exactly which one is going to work best is not established, and the impact of it on the systemic treatments that we have today is not established. One of these drugs works, for example, on type of pancreatic cancer that is Steve Job had, which on his case he apparently didn't get to it on time, but that drug is now approved and it works. It works, and that devastating cancer becomes a less devastating cancer with those drugs. So I have that list that I was telling you, and also they find what we call HER2-neu. HER2-neu is an antigen in several types of cancers. Originally it was identified in breast cancer and is being used there. Now they have identified it in cancer of the esophagus, and we use that, and in the cancer of the head and neck, they're identifying it. So that are the group of drugs that people were working on. Another group of drugs, there is a group of enzymes, we call them mTOR, M-T-O-R. The original inhibitors of it were used for treatment of kidney cancer, worked very good. Now they are starting to use it on breast cancer. And again, they're trying to introduce it for treatment of head and neck cancers, lung cancers, anything they can get their head into that. And do you want more links? I have them on red things for it. So they are the message that we need to receive from these things are like Sutent, Avastin, we talked about that, Nexavar, we talked about that. These drugs are being looked at. We don't know exactly whether they work or not and how much they work. The data is interesting. The standard approach is they have to show it works and then get approval to try it. And their trial should be in a way that they do not put a person who can be treated with a more effective drug in risk. So but the message we all need to get is there are a lot of treatments in the pipeline. And the drug companies, whether because they're nice people or whether they want to make sure the stock stays up, they keep on reporting it every which way they can. And when there is a proof that it works, it will come to the picture. So what we hear most from chemotherapy is the side effects of it. So one of them is asthenia. Asthenia, we use it as a tiredness. There's nobody who gets chemotherapy and says, I'm not tired. So asthenia is a part of it, and it could happen practically with every drug. Anemia and cytopenia is, of course, decreasing the white cells and platelet count. There are treatments for low white cell count. Anemia, it can be treated with procrit or of course, blood transfusion. Platelets, again, with transfusions, and patients are usually overcome these things. And with us being familiar with the drugs, the length of low white cell count will not be usually long enough to jeopardize the patient's health, and the patient recovers from that. Mucositis is what they're talking about to put a feeding tube. Mucositis, we try to say it's from radiation therapy. The radiation therapists try to say it's from chemo, but it could happen. And it's a transient thing. In some of the patients, mucositis will cause a scar formation. There are patients who have been treated not just for head and neck cancer, for cancer of the esophagus, and after the disease is well controlled, the strictures happen. It gets smaller and they have to open it up. Usually gastroenterologists push a little bougie and open it for them. Again, mucositis is transient. The problem with that is it could be a place that some infections can sit on that. So it's good to report it and let the physician take a look at it. And if fungal infections are developing, try to treat that. Diarrhea, again, the same thing. The usual treatments of diarrhea is the standard over-the-counter things. We are careful that some of the patients who get diarrhea who have cancer may have encountered infection from a bacteria called C. difficile, and that requires antibiotic usage. The hospital is very sensitive to make sure that that bacteria, that bug doesn't get into their hospital. So if anybody who's getting chemotherapy and has diarrhea comes to the hospital, they put them in isolation and check the stool for that bug and treat them with antibiotics, and they keep them in isolation until they prove that that bacteria is not in the stool. So it's very important to watch that. Nausea and vomiting used to be a major problem, especially with cisplatin and carboplatin. As you know, today with antiemetic drugs, success is there, and some of them are given into the veins, some of them are under the tongue. So it's very important for a patient who receives chemotherapy not to get dehydrated, because dehydration means kidney damage, and the kidney damage will cause interruption of the treatment for the cancer. Skin rash, especially in people who get Erbitux and Avastin, is significant. And the skin rash usually is managed with the use of an antibacterial cream and salves, and that usually settles down. It is believed that the person who has a skin rash most likely will benefit from the drug more. The reason is that what the Erbitux is blocking is very much present in every organ of a person, and if your skin has it and it starts to itch and get all this skin rashes, means that we're getting the right drug. And it's a general belief, and actually it has been proven to be correct. So be happy about the skin rash. No pain, no gain. Be happy about the skin rash, but don't ignore it. There's nothing wrong they have usually, the company which makes the Erbitux provides a little package for the patients, or you can get it from the pharmacy, some antibiotic cream that you put on the skin, and that makes the rash less severe and doesn't last that long. Allergic reactions are a problem. Any of these drugs can cause allergic reaction. With some of the drugs like cisplatin and carboplatin, when they were the only drug we could use, we used to admit the patients to the hospital and desensitize them. I don't know whether any of you are old enough to remember when penicillin was the only antibiotic, and if they couldn't give it, they had to desensitize them. So my mother says that she got penicillin and it had to be kept on ice. But that's, I think, around Second World War, which I was not born yet. But desensitizing is a solution. So, and for the chemotherapy drugs can be done, and it doesn't diminish the effectiveness of that. The taxanes, of course, as you know, you have to take a steroid ahead of time, because Taxol and Taxotere both can cause significant allergic reaction. And it is believed that the allergic reaction is from what they mix the drug to make it soluble, that can be given into the vein, called camphor. So the new type of Taxol, which is called Abraxane, is in the market, which is supposed to be associated with less toxicity, less nerve damage, less bone pain, less allergic reaction. That is going through the test of time to see whether it works on every cancer or not. We use it very frequently on breast cancers and lung cancers. For head and neck cancer, at present time, everybody goes with the old-fashioned drug until these drugs prove to be as good. Lung infiltration, it could happen. Taxanes again can do that. They can cause pleurisy-type pains, fluid in the pleura, and sometimes infiltrations in the lungs. And when that happens, then it becomes difficult to justify using it again. Kidney damage happens usually with dehydration, and also from the cisplatin and mainly carboplatin. Cisplatin and less frequently with carboplatin. But the dosage of drugs are usually adjusted accordingly. If the kidney fails, they cut the dose correctly. I would say majority of the kidney damages are reversible by appropriate hydration. Pardon?
Hydration once or twice a week.
Hydration once or twice a week will help you not to get dehydrated, but your blood chemistry needs to be checked. Getting hydration twice a week definitely takes away some of the burden from your shoulder, of taking enough fluids. So, and then each time you get your hydration, they check your kidneys function. The blood test they do ahead of that checks the potassium, sodium, and kidneys function. So if something is going wrong, it will alert the physician who is treating you, and they can change the protocol of treatment. Usually they mix cisplatin with a drug called mannitol to make it less toxic to the kidneys. And the kidneys came back. Yeah, that's usually the good news that happens. The fact is not to give up. That's the main thing. Neuropathy could be the type that you mentioned, with tingling and numbness of the hands and feet. Interestingly, some type of pain develops on the legs, especially with taxings, which is very painful and disturbing. Of course, anybody who gets platinum drugs, whether it's cisplatin, oxaliplatin, whatever, we tell them don't drink cold things. They have difficulty tolerating cold. Drinking cold will cause pain on the esophagus. It also causes pain on the legs. Mostly taxing do that. Relief of it comes when you put your feet in the bathtub and open some nice warm water on it. It relieves the pain and then keep the legs warm, and that will diminish the significance or magnitude of the pain that the person has. That usually should improve and as the time goes on. Hair loss, it's temporary. The hair grows back. Yours did, yes. There are remedies to diminish the hair loss. It is best not to use them. One of them is to put ice packs on the head when the drug is given. And when the drug is given, a big concentration of drug is in the blood that can go and kill the hair follicles. By putting ice pack, and they usually put a rubber band around, you diminish flow of the blood to the hair follicles. So the idea is, if I'm treating cancer down here, why do I need the drug up there? This has been used for probably 30 years. There have been cases of recurrence of cancer right on the scalp, which is very disturbing to see that happen. But the hair loss, my suggestion always to the patients is, it's temporary, don't get upset, it comes back. And but that's a remedy for that. After the hair loss is over, the chemotherapy is over, one can remedy the hair loss with the usual things. One thing during chemotherapy to stay away from is Rogaine. Rogaine, that minoxidil, because the way Rogaine works is to increase flow of the blood into the hair follicles. So for a person who is not getting chemotherapy, using Rogaine will provide a lot of nourishment to the hair follicles and makes the person grow the hair. For a person who is getting chemotherapy, if he uses Rogaine, it will push more drug to the hair follicles and actually may hasten the loss of hair. So it works, but timing is extremely important. So that's the timing. I always miss when buying a real estate. I always buy it when the price is high and sell it when it's low. I don't get the message that should be the reverse. So please remember, they use biotin. Biotin is a vitamin B group that helps growth of the hair. Again, it's best to be used when the chemotherapy is not being given. There is a blood pressure medicine called aldactone. It also makes hair growth, and that also helps for reestablishing the hair. We use these frequently on our patients, the female patients who have hair loss, to help them reestablish the hair growth, because a lot of patients with breast cancer, when they overcome the chemotherapy and the hair grows back, then they go through menopause, and the aging the hair loss from aging may prevent them from getting the hair that they wanted to have. So these remedies really helps out very much. But a lot of patients grow back their hair nice and good. I think this could be my last one, but we'll find out. There's another one.
There's more side effects.
Yeah. There are more side effects, which definitely, if you look at every drug, there are major side effects. The side effects like impairment of being able to have children. We call it azoospermia for men, and for ladies, their ovaries start to function. Usually with head and neck cancers, majority of the patients are beyond that age. But for issue of not, for men, they usually do the sperming, they call it banking of the sperm. That is one thing to do. We usually offer it to younger patients who are undergoing treatment for leukemia or these sort of things, or lymphoma, and that delays the treatment for a couple of weeks. If it is doable, that's fine. For the ladies who are at childbearing age, there are ways to protect their ovaries. One is to put the ovaries to sleep. The drug which is used for cancer of the prostate, which is called Luperon, works centrally, prevents the hormones that stimulate production of the egg, and when it prevents it from being produced, the ovaries go to sleep. When the ovaries go to sleep, it is believed that they can tolerate the chemotherapy better, and the person can still be fertile after the chemotherapy is over. Of course, depends on how long the chemotherapy is. There are other ways of harvesting the egg of the patient. They stimulate development of the egg and then they harvest that. This latter one is exciting, but hasn't been very popular. But definitely there are ways to prevent that and make a person be able to have more children. What other side effect comes to your mind?
Blood clot,
Okay.
calcium, magnesium, potassium, and folic acid should all drop below.
The magnesium usually should not go low because majority of the patients who get cisplatin will take extra magnesium.
But if you change from cisplatin to
Carboplatin.
carboplatin,
That's right. So that carboplatin or cisplatin are enemies of magnesium. So that is not the side effect that the patient should suffer from. That's a side effect that the physician should be aware of that.
Yeah, I mean,
So,
I'm taking pills, plus now they're giving me extra bags of
magnesium, yeah. Magnesium usually, the problem with magnesium is that when the magnesium goes down, it brings the potassium down with it, and you need to correct both of them together. But usually, the problem with oral magnesium is that it causes diarrhea. So usually when they give you these drugs, they mix up some magnesium somewhere and give it to the patient intravenously where it doesn't cause diarrhea for them. So magnesium and potassium watching is important. Calcium can go up, can go down. That is part of the blood test that is done. They call it BMP. Every time that the person receives chemotherapy, to check on the potassium, sodium, magnesium, and kidneys function, and making sure that
those minerals also affect your blood pressure.
those minerals,
All over the place.
that's probably a part of it, could be decadron as well as the Erbitox. That can cause high blood pressure. Elastin, your blood sugar goes down.
Over 60 or
Maybe you get dehydrated. Maybe you get dehydrated, yeah.
That's an association.
Yeah.
I was going to say earlier that I we found that more frequent hydration cycle was. Seems like they're drinking all the time.
Sure. Well, because absolutely. Yeah. Now, what we do for our patients is, if they have high blood pressure, we tell them after a few treatments to stop it. because the blood pressure comes down. We just don't tell them to stop it. When we see the blood pressure is coming down, we tell them to stop it. Interestingly, after several treatments, and when we are done with our treatment, the need for use of blood pressure comes back at a later time. Yeah, so that.
It just doesn't seem to be any rhyme or reason to the numbers.
Yeah, it is a, well, kidney is a center for managing the patient's blood pressure. Hydration, lack of it, can make the blood pressure goes down. Lack of nourishment can make the blood pressure down. Loss of weight can make the blood pressure down. So that's why you are being checked for that. But these are the things that patients complain about, and we send them home with it, and we try to tell them to make sure that they use the remedies for it. One more thing.